can see and hear me okay and see our slides. I just wanted to thank everyone for joining us this morning. We're excited to have you here and to be able to talk about the healing power of pleasure today. I'm Stephanie Taylor. I'm a sex, couples, and trauma therapist at UC and co-presenting with me today is Heather Hill.
And I am Heather Hill. I'm an occupational therapist currently working in pelvic floor therapy.
So before we get started, I just kind of wanted to go over a couple housekeeping items. I know this is kind of an ugly slide. There's a lot of information on here, but basically what it's saying is this is a sensitive topic. So exercise professional judgment and your application of what we go over today. You should have also received this when you registered, so hopefully it looks familiar to you. And then of course you'll get a copy of the slides to refer back to this. We have a lot of material to cover today. So we're going to be moving kind of quickly just to make sure we get to everything before noon. But because we're going to be moving kind of fast, if we don't get to questions that are in the chat, Heather and I have agreed to kind of stick around for a while after. So if there are any questions that you would like answered, and if you're able to stick around, that's great. And if you're not, we're going to include our email addresses too. So feel free to send us those questions separately. Couple of disclaimers is no conflicts of interest for today, no commercial support. We're going to be talking about some sensitive topics and language, so I definitely would say it's not suitable if there are children around. So if that means putting in some headphones or maybe going to a different room, a heads up. And if you're not able to do either of those, then again, you'll receive the recording to kind of come back to. So who is this presentation for? You do not need to have any specialized sex education or therapy training to attend our presentation today, nor is this any kind of replacement for specialized training. So I think we're not trying to dissuade anyone from seeking the training. However, we do recognize that trainings aren't always the most accessible, and nor are they needed to provide ethical and holistic care. So we're going to try to center around this model of pleasure rather than sex and sex therapy. So we hope to be able to provide you some confidence and some tools to add to your holistic standard of care. And just our clients' sexuality is a significant aspect of overall well-being. So if you consider yourself a holistic practitioner, this presentation is for you. And we have a couple of goals for today. So I just want to take note, we did not mention sex or sex therapy in the title of this presentation, and we did that intentionally. Today, we're really trying to emphasize pleasure instead. So our goals are for each of you to leave this presentation knowing how important it is to address the sexuality and the sexual health of our clients, to know what pelvic floor therapy is and when to refer, and to feel confident on how to best address sexuality by instead focusing on pleasure. And we've got some specific interventions, practices, and tools for the end of the presentation that you can try out, and maybe hopefully it will help enhance your practice. And also, I just want to say my colleague, Dr. Whit Scholars, gave an excellent presentation earlier this year, kind of how to break the silence and talk to our clients about sex. So I kind of consider this a part two to that presentation in a way. So who are we? Why are we talking about sex? Start with Heather.
So my name is Heather Hill. I am a certified and registered occupational therapist and a yoga instructor. And I'm currently working in pelvic floor therapy at Uplift Pelvic Health and Wellness, which is here in Mill Creek, Utah. I am very passionate about pelvic health as its transformative and major impact on quality of life. And I'm really excited to be here today presenting with Dr. Taylor. I think the collaboration of mental health practitioners and pelvic floor therapists is so important, especially for the population of people experiencing pain or dysfunction with intercourse. Because between you and me, we are really the clinicians that are spending the most amount of time with these clients. And so It's really important that we're in collaboration because we are really leading the front here in regards to treatment for this population. And we can be the bridge for these clients who may not be getting this information elsewhere.
I'm a clinical psychologist. I specialize in trauma and couples therapy, so Gottman for couples, EMDR for couples. And I've kind of realized that with the trauma therapy in couples, there's sort of this missing piece of the puzzle. And to me, that felt like sexual health. And so last year, I'd completed ISTE's sex therapy informed training, which I highly recommend. I loved it so much, I decided to do the sex therapy certification at CIIS, which is what I spent kind of the first half of this year doing. And so, what I've noticed is that addressing sexuality with clients, individual clients, and couples, there have been some pretty powerful shifts. So, for the couples, there seems to be this sort of microcosm of the relationship. So, sexual connection, their sexual life seems to kind of mirror these deeper issues in relationships. And so, kind of by prioritizing or focusing on the sexual piece, it seems to be a much more efficient process, meaning more effective, more rewarding earlier on. And then I also noticed a similar microcosm for individual clients, but more importantly, I noticed with those clients that sex, whether that's solo or partnered, really seems to be the quickest way into the body. And so, for those who have experienced trauma, sexual trauma or otherwise, that tends to be an experience that kicks us out of our bodies or disconnects us from our bodies. And so, just noticing that sex, when it's done in sort of a safe and controlled environment, can be a really powerful and even elegant way back into the body. And so, what we're hoping to do here is really kind of focus on ways we can bring this into our own practice by focusing on pleasure rather than specifically sex drive or on sex therapy. And that is what we're hoping to share with you today. So here's our agenda, just to kind of orient us. We're going to spend a little bit of time talking about sexuality and mental health, giving kind of an overview of traditional forms of sex therapy as opposed to more contemporary forms of sex therapy that center around a different type of model. Um, I'm going to spend a little bit of time talking about pleasure in and of itself and sort of the healing power behind that. We're going to look at psychological barriers to pleasure, and then we're going to shift to physical barriers. So, Heather will jump in, talk about what pelvic floor therapy is, when to refer to a medical professional or specifically a pelvic floor therapist, and then she'll go over kind of what that treatment looks like. And then we will end with some practical tools and exercises that you can hopefully incorporate into your own therapeutic practice. So we like to start off with a couple of polls for today. So hopefully our polls will, oh, there it is. So starting off, just curious, who is in the audience today? Are you a mental health professional, pelvic floor therapist, other? Oh. It's looking like a lot of mental health professionals in the audience. Not seeing any pelvic floor therapists. Hopefully you can see these results too, but I'm showing 79% mental health professionals, 21% other, which is great. Okay, and then this question is just for our mental health professionals joining. I'm just curious, what is your specialty? Are you a couples therapist, sex therapist, both? Do you address sexuality? Do you tend to avoid it? I don't know if the poll is showing up.
It's not working. Maybe everyone could just put it in the chat.
Okay, let me open up the chat option. Yeah, if you don't mind just sharing a little bit of your
Oh, now it's
specialty.
working. Here we go.
Oh, okay.
Oh, wrong one. You can do this one.
We'll just jump right ahead. So yeah, level of comfort talking to clients about sex. Okay, looks like people are still answering. Okay. Hopefully you can see those results. So we got a lot of people feel extremely comfortable, fairly comfortable, comfortable enough. Small percentage feels uncomfortable. So I'm going to stop sharing that. And then, oh, there's the specialty. Okay. And then going back to your specialty, if you don't mind just taking a second and filling this out too. Okay. So we got a combination of people in the audience today. So some sex therapists, couples therapists, sex and couples therapists, people who don't identify as either, but they do discuss sex, and then a handful of you that don't identify as either of those and typically don't discuss sex. So good information. Thank you for sharing. I'm gonna try to. Okay. So I would like to just start with the importance of addressing sexuality. So just kind of looking at, there's a lot of good information around how often sexuality gets brought into therapy sessions, noting that a lot of couples that seek therapy tend to report having unaddressed sexual concerns, and just kind of considering how important that is for the significant aspect of our mental health. I think the most interesting thing is this study that I've listed here that found that sexual satisfaction was a significant predictor of general life satisfaction, even more so than relationship satisfaction, which I thought is really interesting. I gave a presentation a couple of years ago about how important relational therapy is and how the relationships in our life tend to be directly correlated with overall quality. So, kind of getting even more specific of looking at our sexual life, our sexual connections, and how that contributes to that as well. And then, yeah, looking at sexuality as a powerful tool for healing and growth. And really just wanting to highlight this last piece here. We do have an ethical responsibility to address the whole person, and that does include the sexual self. And then just looking at limitations and consequences to not addressing that. So incomplete treatment is a pretty big one, just knowing that that can significantly impact mental health being, our mental well-being, and that unresolved underlying issues, meaning that sexual difficulties or traumas can contribute to mental health problems. And so not addressing them can kind of hinder progress in therapy. Lingering symptoms, mental health symptoms may persist or worsen if related sexual health issues aren't addressed. It's a big missed opportunity for growth. So again, kind of just thinking about sexual health can lead to increased self-esteem, improved relationships, a greater sense of overall well-being, negative impact on relationships. So that can lead to relationship problems. It can even impact the relationship that we have with our clients. And then knowing how that's directly related to mental health concerns. And then it perpetuates shame, which I think is a really important piece here. I think we all kind of know how impactful shame can be. Um, and I'll be honest, I don't think I've ever met somebody who hasn't reported some type of shame related to some aspect of sexuality, whether that's going back to childhood or as they've come into adulthood. And so just being able uh, to name that, shame is sort of like this creature that lives in a dark basement. And so being able to bring that up into the light kind of helps take away its impact, and recognizing that when we don't open that door and we don't allow our clients to bring this to us, we're just kind of adding to that. We're keeping it in the basement. So, why do you think so many healing professionals don't address sexuality? So, we don't have a poll for this, but if you don't mind just using the chat option, if I can figure out how to Accesses. Just throw a couple ideas in there. What do you think gets in the way of clinicians talking about sex? Education, culturally taboo, lack of training, because we live in Utah, trauma, fear of talking about it wrong. Yeah, all great, all great considerations here. So yeah, I'd say definitely personal discomfort, just in general, our own biases, maybe our own shame that's associated with that. Just like you shared, lack of formal training, fear of inadequacy, cultural taboos and societal stigmas, being able to address cultural diversity. And then there are some pieces too, as I was looking this up, symptomatic focus seems to be part of it. So some clinicians feel more comfortable or more focused on parts and not the whole. And so if someone seeks help for a specific mental health issue like anxiety or depression, uh, we might be more tempted to focus on those symptoms rather than getting into the sexual health piece. And then lastly, client preference. Some clients just might not be ready or willing to discuss that, even if it's related or connected to their mental health concerns. And so I'll talk about this last one in just a second. But I just want to say the truth is, we are doing a disservice to our clients when we avoid this conversation. It really does limit our clients' health and growth. And I think hopefully you'll see by the end of this presentation, you don't need to have specialized trainings to help our clients kind of explore this aspect of their lives. Just being open and willing to have the conversation. I think clients are often relieved when we initiate the dialogue because it really does kind of validate their experiences and their concerns. So just kind of coming back to core pieces of being an effective mental health professional, having open communication, creating that safe, non-judgmental space for clients, inviting them to bring up all aspects, including sexual health, being able to work collaboratively with our clients and respecting their boundaries, understanding their level of readiness to talk about that, and then comprehensive assessment. Just good therapy comes from having a good understanding of what's going on. And that can be a thorough evaluation of sexual health, or it could be a much less thorough assessment with just a couple of questions. So, what exactly does that look like? How do we assess our clients' sexuality? And when do we do that? So the answer is as early as possible, ideally in an intake session. Again, clients might not be ready to talk about this or might not want to talk about it, but it's our responsibility to open that door. And so just even thinking about working in a couple pieces in an intake. And then what are the questions? How do we kind of open that door? Dr. Witt Sandal Scholars gave a couple of really good questions to pose to kind of get that conversation going. My personal favorite question, the one I use the most, is one that I learned in that ISTE training, which is when is the last time you had sex and how was it? And it's just such a simple question. It works for individuals, it works for couples. It gives adequate permission. And then you just get so much information from this question, even if sexuality isn't a concern that our clients are coming to us for. So, for example, if you're working with a couple and a couple talks about a desire discrepancy and kind of one person has a high sex drive, the other partner has a lower sex drive, even though we don't really think about sex in terms of drives anymore. But what does it actually mean? So just getting some like very specific numbers with that. Like, did you have sex right before our therapy session? Was the last time 5 years ago? So kind of getting some numbers there. And then thinking about, were you able to have sex? So again, are there any physical concerns that are coming up, like erectile dysfunction or premature ejaculation or pain during sex seems to be a pretty common one. And the reason why you want to ask that question specifically is as you're putting together a treatment plan, you want to know if you are going to need to include any type of referrals to medical professionals, including a pelvic floor therapist. And then I also love this question because it kind of asking how it was and getting to that quality piece kind of implies purpose or values for our clients. So for example, if a client says, last time I had sex was great, I felt really emotionally connected to my partner, that's good. That speaks to that emotional connection as being an important piece. If they say the last time was not good because one partner didn't have an orgasm, that's helpful just to know that maybe they kind of think about sex in more of a goal-oriented way, placing value on orgasm. And then you can also ask individual clients who are not in partnership, and you can ask the last time they self-pleasured. It can work the same way. Asking how it was kind of gets you a sense of maybe why they engage in that. Is it just to kind of scratch an itch? Is it to relieve stress? Is it to feel connected in their bodies? Is it just because they're bored? So lots of different answers to a really simple question. And it can really kind of help as you're kind of formulating a treatment plan. So why do clients seek sex therapy? If clients come in, they want to talk about things related to their sexual health, just kind of considering a list of what might bring somebody into sex therapy. I'm just curious, what do you think is the most prevalent reason people would seek sex therapy? You can just throw some ideas in the chat if I could get back to it. Sorry, I'm just seeing a question here. Specify between partner and sex and masturbation. Ask a question. I like to just ask it very open-endedly and just see what comes up, because maybe there's more masturbation, maybe they haven't had sex with a partner for a while. And if they're there for couples, or if they're there to talk about sex in a relationship, then I might get more specific with that. Desire discrepancy, sex frequency, value conflict, pain and difficulty when they're struggling with relationship intimacy, post-pregnancy, yeah, it's a big one. Trauma, big one. To explore interest in kinks, relationships, sexual attraction. Yeah, and then some physical pieces here. So yes, all of these are reasons people might seek sex therapy. The most common one is a combination of a couple that you've just shared today. So Heather, if you could click the next part of this, yeah. So people are looking to explore communication breakdowns around sexual issues. And what that leads to is that lack of communication can often result in mismatched libidos, kind of like you shared in the chat, intimacy problems like you shared in the chat. So it's kind of like a combination of a few of these, but just kind of going back to the beginning part of this, it's the communication piece. And so how do we actually talk about this? And so we're going to get into some specifics with this, but I want to just give a quick little overview of what traditional sex therapy has considered in terms of how we're conceptualizing sexuality and sexual concerns. And so that really falls back on the desire model. And so again, this is a very specific linear way of understanding sexual response. So it starts with spontaneous desire, which then leads to arousal, plateau, orgasm, and resolution. And so just a quick side note for those of you not familiar with spontaneous as opposed to responsive desire. Spontaneous is that sort of sudden urge that can come up, sometimes not even with an external trigger. And I think it's going to be the type of desire that is most often portrayed in media. So in books and movies and porn, there's this sort of idea of people who are, you've seen the scene, right? Like a couple comes in and they're so turned on that they are ripping each other's clothes off before they can even shut their front door. So that kind of idea of it happens, we move through it. And that is going to be more of a typical or expected type of desire that you might see earlier on in a relationship. And sometimes it is more specific maybe to those with male bodies. So what is responsive desire? It is that desire that arises in response to something. That could be physical touch, kissing, It doesn't even need to be sexual. It could just be a sensual atmosphere, an emotional connection, stimulating conversation. This is the desire that emerges as you engage in pleasurable activities. So just a quick overview of those two things. So going back to the desire model, it really overemphasizes the spontaneous desire piece. And I think you can probably start to guess there's some pretty big limitations with this model. It doesn't quite recognize that there is a lot of variation among individuals. Some have lower or fluctuating levels of desire, and it's not considered a dysfunction. And I think the biggest issue that I have with this is that it is a problem to be solved, and it pathologizes all types of variations with individuals. So in the next slide, I've kind of got a list of a couple of these limitations, but I'll just go over these. I think there's this unrealistic expectation that gets placed on individuals or couples to have this sort of ideal level of desire, which is not realistic, especially knowing how that fluctuates. There's an overemphasis on performance. So kind of this idea that performance might kind of help balance that out. And then it really does neglect non-sexual intimacy. So it's placing so much on this sexual desire, and it kind of just overshadows other forms of closeness, emotional connection, intellectual, spiritual. And that doesn't really fit for those who have been in long-term relationships, because you're going to see a lot more of these other ways of connecting that kind of form over time. Reinforces stereotypes. So again, kind of thinking about, uh, men are expected to have a certain type of desire, and it doesn't quite fit with women or those with female bodies, marginalized groups, which are going to be much more likely to experience that responsive desire. It completely excludes those who identify as asexual. So those who experience little to no sexual desire are going to feel marginalized by just focusing on a desire model. There are cultural biases here. If we've got clients that aren't from a Western background, there are a lot of cultures that really don't see desire as central to sexuality. And then I think, again, going back to this dysfunction piece, we're really kind of then medicalizing the desire issue. So that's going to lead to a focus on pharmaceutical interventions like testosterone therapy or libido boosting drugs. And that kind of fails to neglect maybe some of those deeper emotional or relational issues. Also neglects trauma and psychological factors. Ultimately, it leads to limited treatment options. So the sort of narrow focus on just increasing that spontaneous desire, and it overlooks a lot of really important aspects of our sexual well-being. So a lot of limitations, didn't even fit them all on that slide. And so just thinking about that was traditionally the model in sex therapy. Contemporary sex therapy tries to incorporate a much more holistic and nuanced understanding of sexuality that's not just specific on desire, and instead it focuses on pleasure. And as we talk about the pleasure model, I just want to say this is not just about sexual pleasure. All forms of pleasure are brought into this model. And so here's just kind of a quick overview of what that model entails, and just to kind of get a sense of it. And then I'm going to go into much more detail about what the practices are, or even some exercises that you can do to bring in more of this with your clients. But basically, we are centering pleasure here. That becomes the primary focus. And I also just want to say, just terminology wise, the desire model versus the pleasure model, desire implies lack of something. And so it's kind of like you're not to that point yet. There's a longing, and that can feel good, and that can also add to anxiety or stress, which is going to be the exact opposite of feeling sexual. Pleasure is all about the present moment. And we have tons of research that kind of shows mindfulness and how powerful it can be to be in the present moment. And pleasure is such a quick way into that. And again, not just sexual. So the pleasure model really is, we're focusing on a couple of core principles here, consent, communication, connection, um, and we're really kind of looking at focusing on an enjoyment rather than performance. So there is a TED Talk that I love that kind of, I don't know if we have time. It would be fun just to watch the first couple of minutes because the speaker is pretty engaging. He carries it a little bit further, but I think what I really like about the pizza metaphor is we're talking about choice, we're talking about variety, preference, and the best part is it really is encouraging communication. And I think, again, kind of going back to number one reason people come to sex therapy and how if we focus on that piece, that can kind of help bring more to the table with that. So again, lots of different ways to eat pizza, lots of different types of pizza. And it's definitely more inclusive and leads to kind of healthier conversations around that. So this is my stretch here of saying pizza feels more like the pleasure model as opposed to the desire model, which again is that sort of linear progression when we understand sexual response. And so kind of really just thinking about how we can encourage an exploration with our clients that is similar to talking about pizza preferences. So going back to the pleasure model, I think we can kind of start to see there are a lot of benefits of this over the desire one, especially since it's much more inclusive and it includes the responsive as opposed to just a spontaneous desire. Um, and it is much more reflective of real life sexual experiences, especially when we start to consider long-term relationships. While focusing on pleasure, that takes away that pressure of performance anxiety. It's really effective in looking at things like low desire arousal issues because we're not pathologizing it, we're just getting curious about it. And it can be really kind of empowering for clients because it promotes self exploration and body positivity, and then just fosters a much more positive therapeutic experience. So I think the term sex therapist can be kind of intimidating for clinicians and clients. And so I really kind of want to reframe this approach of thinking of yourself as a pleasure therapist and really just kind of, again, centering pleasure as we talk to our clients. And that kind of shift really looks at overall well-being and enjoyment, not just about performance. You don't need the expensive specialized training to help our clients explore pleasure. We just need an open mind, a willingness to learn, an ability to create a safe, non-judgmental space, which hopefully we're already doing. And again, just thinking the pleasure model really is looking at creating a space for curiosity and looking at things that bring our clients joy. And we are not teaching techniques. We are facilitating self-discovery and healing. So I want to just deviate for just a second and I want to talk about pleasure in and of itself. So, and we'll again come back to kind of ways to bring, ways to center pleasure in our own practice, but really just thinking about pleasure and how important it is for clients who are coming to us in pain or have had trauma. Pleasure is such a quick way to reconnect with the body. It builds trust and intimacy in relationships and enhances self-esteem and self-worth. Um, and I think it's also really interesting too when we look at kind of the chemicals in the brain. There's a very different reaction of things that are happening when somebody is experiencing desire as opposed to pleasure. Pleasure has this sort of neurobiological system where we're getting a release of endorphins, which reduces cortisol. We're getting a lot of the oxytocin chemicals released, which is sort of that bonding hormone, dopamine, that feel-good hormone, and and there's a neuroplasticity aspect to this too, where we have enough of these positive experiences, we start to rewire the brain to help it become a bit more resilient against stress and trauma. and kind of repatterning those negative thoughts and emotional cycles. And so really by focusing on pleasure, we're kind of allowing our clients to create new, healthier neural pathways. And then there have been some interesting case studies too with clients with chronic pain, and they talk about kind of reduced symptoms and reduced pain after they incorporate daily pleasurable activities. And again, sexual and non-sexual. And then for those of you who work with clients who've experienced trauma, you know how powerful of a shift it is to get someone from that sympathetic to that parasympathetic nervous system. And so because of the chemicals that come up when you're focused or engaged in a pleasurable activity, that is a really quick way to kind of shift into that nervous system. So pain isn't necessarily the opposite of pleasure, but thinking about pleasure sort of a pathway through that. And then just to kind of keep in mind, trauma freezes the nervous system. Pleasure can be a way to melt it. So we know trauma and pain live in the body, and just remembering that pleasure does too. Doesn't have to be sexual, but it is connected to how we experience joy and connection. So what are some common barriers to pleasure? And so we're going to start with psychological here. Just thinking about what might get in the way, why might it be difficult to kind of focus or center around pleasure. Kind of a list that I put together. I'm sure maybe you can think of some more, maybe add some of them in the chat. But just thinking about what's going to get in the way of a client to be able to connect with their sense of pleasure. One of the questions that came in before the presentation was, I think the question was, is pleasure selfish? Or how do we talk about that if clients kind of consider focusing or prioritizing pleasure as selfish? And I like to think of pleasure as sort of under that umbrella of self-care. And it's slightly different. Self-care is a bit more specific on how we talk to ourselves as we're engaging in an activity, but similar idea here. And if social media has taught us anything, we know that self-care is not selfish. You can't pour from an empty cup. All of those things that we're kind of hearing a lot of lately. Same thing with pleasure. When you prioritize that, you're going to a reduction of all the things that might take away, and it actually ends up doing the opposite. It increases motivation, increases energy even. And then, of course, you're going to get the benefits of the treatment, whatever it is you're coming to treatment for. So yeah, here, that's the psychological piece. And now I'd like to kind of shift gears here a little bit and hand it off to Heather to really kind of explore the physical barriers to pleasure and to talk about pelvic floor therapy in general.
Okay, so let's begin by just talking about what is pelvic floor therapy, who can do it. Pelvic floor therapy is a specialized type of therapy that focuses on conditions related to the pelvic floor, and we will get into more specifics related to those conditions throughout the presentation. Both physical therapists and occupational therapists can become pelvic floor therapists. So first you would get your training and degree in OT or PT, and then you take specialized courses to become a pelvic floor therapist. So if there are any OTs in the audience that are under that other category of listeners today, if you are interested in pelvic floor therapy, I've listed some of the courses I've taken in the reference slides. We also got a question prior to the presentation about what is the difference between a pelvic floor therapist and, say, a gynecologist or a physician. So just to clarify that, a gynecologist or your doctor, your physician, is able to diagnose conditions and prescribe medications. And a pelvic floor therapist is really going to be leading the treatment for the body, more of the physical treatment, weekly sessions, one-on-one time that's much lengthier than what a physician can provide. So let's talk briefly about some pelvic floor anatomy. We obviously won't have time to get into specific names and too many details about the anatomy here. If you are listening to this presentation at home and you have the ability to stand up, perhaps standing up here and palpating your own body. I love to have hands on my own body for these kind of activities. So palpate your pubic bone, which is this bony prominence at the mons pubis or at the base of your abdomen. And then with your other hand, palpate your tailbone. So at the very base of your spine, where the spine starts to curve under. You can see from our pubic bone to tailbone, there's this group of hammock-shaped muscles. Those are our pelvic floor muscles. And we have over 20 muscles that are associated with the pelvic floor. But what's more important here than just naming the muscles is really talking about the physiology and how those muscles function. So our pelvic floor is part of our core system. So if you can just imagine, my hand up here is the respiratory diaphragm. Our core system is really everything from respiratory diaphragm to the pelvic floor muscles and in between. So the core muscles, the spine, the organs, fascia, everything housed in that core system. And that's important because our pelvic floor muscles are not just operating in isolation alone down here, but they're really inextricably connected with this core system. So when we treat pelvic floor issues, we're looking first at this core system, and then branching out from the core system, we know the legs, the lower kinetic chain, the shoulder girdle, really any part of the body can have an effect on the core system. And if one part of the core system is failing or not functioning optimally, it's usually the pelvic floor that will take the brunt of that dysfunction and manifest as symptoms at the pelvic floor. The functions of the pelvic floor: sexual pleasure is a function of the pelvic floor. We have our bowel and bladder, or that sphincteric function, supporting organs, stabilizing our hips. We actually have a muscle that's in that hammock-shaped group of musculature that actually dives out of the hammock-shaped group and connects at the outer hip. It's called our obturator internus. So if you've ever wondered if the hips and the pelvic floor are related or connected, they absolutely are, and in some cases only separated by a ligament. Another function is birthing babies and lymphatic drainage, or that sump pump. So really the ability of the muscles to pump blood flow and lymphatic fluid back to the heart. Some conditions that we treat, I'll start by saying here, both men and women have pelvic floors. Women have two approaches for internal work, transvaginally or transrectally. Men have one approach for internal, transrectally, but we both have pelvic floors. We both have that hammock-shaped musculature at the base of our core system. So when we treat pelvic pain, that could be male or female. Typically, someone may come in with a diagnosis or without a diagnosis. So we really can treat a wide variety of pelvic pain conditions here. Some of those conditions that you might come in with a diagnosis would be endometriosis, which is where uterine-like tissue is actually growing outside of the uterus and can form endometriosas. Our pelvic congestion syndrome is another condition we see often, which is where the veins of the pelvis are not functioning optimally. Vulvodynia, that's where you're going to have burning or irritation at the vulva, the entrance to the vaginal canal. Trauma can create pelvic pain, whether that's sexual trauma that's happened at the pelvic floor or trauma to another part of the body or in another part of the body that is manifesting and symptoms are happening at the pelvic floor. Pain with intercourse it can be related or unrelated to a chronic pelvic pain condition or diagnoses. So there's a lot of nuance there. And when we see people for pain with intercourse, this is another reason I love collaborating with you all to learn some of these tools for really getting at their symptoms. Pregnancy and postpartum is a condition we treat. So a lot of people now know that seeing a pelvic floor therapist postpartum can really help with your recovery. But we also recommend highly for people to come in during pregnancy to prepare for birth and treat any pains that are coming up during pregnancy, and also just prepare the body for a smoother postpartum recovery. Giving birth is likely one of the biggest physiological events that will happen to your body, so it's really important to train for that and to prepare those pelvic floor muscles for that. Diastasis recti, that is when our abdominal muscles separate and don't come back together fully. Pelvic organ prolapse, that's where some of your organs may slip down from their original position and be bulging into the vaginal canal. Back pain, tailbone pain, and hip pain. Depending on the research that you read, something like 70 to 90% of back pain has a pelvic floor component. So that can be really helpful to get an assessment from a pelvic floor therapist if your clients are suffering from back pain and that's limiting their ability to connect with their partner. Urinary leakage or incontinence, bowel incontinence or constipation, and more. So we've had people come to see us that weren't necessarily experiencing any dysfunction or any of these conditions above. I had someone who came to see me who just wasn't feeling much internally with vaginal penetration. She wasn't experiencing pain, but she did want to start feeling more sensation and she wanted to have vaginal orgasms. So we worked together on that. Another client came to see me with the goal of having a flat stomach and feeling more connected to her core. And by the time she was done with her treatment, there was this dress that she could not wear after giving birth to her children because her rib cage had expanded. And she always would have to wear shapewear with tight clothes. After her treatment, she's now wearing that dress and not needing shapewear and feeling much more confident in her body. And also, like Dr. Taylor mentioned, changes in your self-image, changes in your body due to, whether it's pregnancy, postpartum, injury, or even aging. We love treating people with all types of conditions. So let's get into some of the pain neuroscience that informs our understanding and treatment for people experiencing chronic pelvic pain and pain with intercourse. The study of pain is incredibly complex, and so there's not enough time in this presentation, and it's not necessarily what you signed up for me to go into too many details here. So know that this will be a very basic overview, but I'll try my best to connect the dots here. So we know that the study of pain is complex, and at the same time, it's really important for us to be educating our clients on this. So we call this the iceberg effect, which is where, we may be seeing a client in the clinic for 1 hour sessions, and maybe 20 to 30 of that is all we have time for to educate on pain neuroscience. And that's really just the tip of the iceberg. And there's so much more we need to know as clinicians to guide our rationale for treatment. And the most effective education on pain neuroscience is simple, makes sense to the client, and relates back to their goals for therapy. So our tissues contain what's called nociceptive receptors, and these are not pain receptors. These are more of basically danger alert fibers in the tissues. So just like your eyes contain light receptors, not vision, and your ears contain vibration receptors, not hearing, our tissues contain these nociceptive receptors, not pain. So there are no pain fibers in the body. The tissues will really tell you what's going on, whether there's a threat or not, but then the brain ultimately makes the decision. So this is a fundamental shift in how we've been thinking about pain, as pain is 100% produced in the brain. So pain and injury are not the same thing. Dr. Adrienne Lowe, who is a neuroscientist and a physical therapist, really leading the neuroscience education in the physical therapy realm, he illustrates this with 2 documented occurrences in medicine. So first, there was a South Korean man who woke up one day with a headache. Eventually, he went to the doctor. They took a scan and they found a nail in his head. And he was able to recall when that injury had happened. He had been a construction worker 4 years prior and remembers the incident where that likely happened. So there's an example of an injury with no pain until about 4 years later. Second, we have the story of a construction worker who stepped on a nail and it pierced through his boot. He had horrible pain, couldn't calm down, given the highest doses of pain medicine, and still felt pain. And in the ER, when they were able to cut off of the boot, they saw that the nail had actually gone between two of the toes and did not actually penetrate skin. So there's an example of no injury yet an excruciating pain experience. So injury and pain are not the same thing. And the bottom line is our tissues will heal after an injury, yet our pain can go on and on and on. So why is this? We need to look at our nervous system's role in the pain experience. So we have an amazing nervous system, the most sophisticated alarm system on the planet, and it has the ability to enhance or decrease some of the signals coming its way. If you pulled out all the nerves in the body, it would be 45 miles long in our nervous system. And we have these ion channels that are along the nerve axon, and they allow for information like temperature, movement, stress, immune function, blood flow, etc., to impact our experience of pain. So these ion channels can explain some of those odd pains in the human body. For example, when someone says, when it's cold outside, my joints hurt. That is an ion channel that's sensitive to temperature. So in the experience of pain, more ion channels can be opening and be hypersensitive to detect information in a certain area of the body, which leads to increased neuronal excitability and amplified pain signals in those areas. So even after the tissues heal or the threat of injury is over, these ion channels along our nervous system can still be hyperactive and still be taking in information at that area of the body. So let's talk about the nervous system and the brain's ability to change, which is this concept of neuroplasticity. So this concept is hugely important in pain neuroscience. You may have seen a map of the homunculus, which is our biologically coded representation of the brain's motor and sensory distribution, where areas that we use a lot are largely represented in the brain, like our hands, lips, mouth, face. And we really keep this map alive by movement. Fun fact about the homunculus, we can scan a musician's brain maps and tell them what instrument they play just by looking at the brain map and which areas of their body have more space on that brain map. And changes to the brain maps can occur in minutes. So, for example, when you are wiggling your fingers, there's an area of your brain that recognizes you have 5 fingers. And if we were to tape 2 of your fingers together and now you are wiggling 4 fingers, that same area of your brain that recognized that you had 5 fingers will interpret it as 4 fingers in as little as 15 to 20 minutes. So these neuroplastic changes do not take days, months, years as we previously thought. They are happening in minutes. And so how does this relate to people with pain? Well, the experience of pain is causing neuroplastic changes quickly. Some of the changes include blurred edges on the brain's mapping, not knowing what part in the body where you're feeling, greater areas occupied in the brain, so an enlarged map, really being hyper aware of a certain part of the body that maybe typically doesn't have that much of an area on the homunculus, and then left versus right confusion in the body. And we know that when the brain starts questioning its maps, the threat level goes up, and therefore more of those ion channels might open to interpret, is this a threat or not? And someone may experience more of a pain experience. Which leads us into the pain neuromatrix. And this is an individual's experience of pain. This is the map and the connections where areas of the brain light up when we are experiencing pain. A typical pain neuromatrix involves the premotor and the motor cortex, the cingulate cortex, prefrontal cortex, amygdala, sensory cortex, hypothalamus, thalamus, cerebellum, the hippocampus, and the spinal cord. So that is a lot of parts of the brain. And we know those areas of the brain are so important for other functions and other jobs. But when we are experiencing pain, pain will come and hijack those parts of the brain. Chronic pain will enslave them. So for example, someone experiencing pain and their movement is suffering, you might say, oh, the movement area of the brain is in a pain meeting. Or if they're in pain and their attention and focus is suffering, their attention and focus area of the brain is in a pain meeting. And every person's pain neuromatrix is different, which makes treatment so complex, that pain is not produced in one single part of the brain. So when it comes to pain, the brain asks one question: am I under threat? And it asks the pain neuromatrix, how dangerous is this? If it does perceive a threat, it wants to know more, and it opens up those ion pathways, those channels, which is called facilitation. And if it doesn't perceive a threat, it will shut down the pathways, which is called inhibition. So people experiencing chronic pain, their inhibition pathways, the shutting down of information, just gets taken out of the equation, and they are more constantly in an open pathways facilitation. This is why the brain and pain neuroscience is just a key aspect in the study and treatment of pain. Taking it even further to talk about stress biology, when pain is perceived as a stressor, what happens to our system? So our nervous system is beautifully designed to ramp up and calm down, ramp up and calm down, and we use adrenaline and cortisol to do this. If you live under long-term stress, your system shunts or your system ramps up, but it's not coming back down. So what does this have to do with pain? Pain is the long-term stressor. If you think about it, living in pain is not normal. If you're waking up every day in pain, it's costing money to go to doctors, it's adding stress to your relationships. These people experiencing chronic pain, their immune system is constantly shunting or going up, but never coming back down. And the side effects of this are going to include sleep deprivation, sensitized gut, overactive muscles, atrophy of muscles, or hypervigilance. These side effects are somewhat due to the hormones produced in the stress process, adrenaline and cortisol. And when you live with cortisol, your muscles are going to become sore, sensitive, tired, fatigued. Bigger muscles get overactive and smaller muscles get underactive. So notice that I'm not saying your muscles are becoming torn, bulging, ruptured, broken. So this is something that we can work with as pelvic floor therapists, as occupational therapists. We can work with sore, sensitive, tired muscles. We can work with overactive or underactive muscles to retrain how those should be functioning. And then taking it even further with this stress biology, if you're living with that cortisol in your body, it will have an effect on your immune system. So people with chronic stress have higher pro-inflammatory cytokines. So it makes your nerves more sensitive. And that persistent inflammation, by the way, is going to alter the brain plasticity because it alters the blood-brain barrier. So bottom line is, pain is way more complex than injury. It's going to include your immune response, your stress response, and it really has a long and lasting consequences for the patient. So pain neuroscience education is really all about taking all of this info and putting it into a language that the patient can understand. That we don't have pain fibers in the body, we have nociceptive fibers. They're going to signal to our peripheral nervous system in those ion channels, which is going to ramp up to the brain. The brain is going to have a meeting and decide if it's under threat or not. What? Okay. So some treatment modalities that we use in pelvic floor therapy include these listed on the slide. Breath work is huge. So just like I talked about in the anatomy section, our respiratory diaphragm is the top of that core system and pelvic floor at the bottom here. So the way the diaphragm moves when we are breathing affects the system and affects our pelvic floor muscles as well as our pressure management. So evaluating and training a person's breathing patterns is really foundational step one for pelvic floor recovery. Nervous system regulation. So we know, based on that pain neuroscience we just talked about, there is no pelvic floor healing without nervous system healing. So we can go in all day long, talk about posture, release tight muscles, but if we're not also working on the nervous system and the nervous system isn't making changes, that person will go back to those patterns in their body. And so this is really why I love collaborating with you mental health clinicians, because this is, really your area of expertise. And I've learned a lot from meeting with Dr. Taylor and from other mental health professionals that are, leading the front here. Some tools that I use in my practice for nervous system regulation include tapping, when a person brings up part of their experience and has an emotional response, or when maybe they're laying on the table and we're working on their body and an emotional response comes out. Listening to bilateral stimulation music, especially while we're working on tender tissues or if we're doing internal work in the pelvic bowl, it can be really healing to have that bilateral stimulation music on. And also guiding patients through different breath work, visualization, and mantras. We also do visceral mobilization, which is a soft, hands-on approach to help facilitate appropriate mobility, tone, and motion of the viscera, or the internal organs of the body. Manual therapy, so this could include that internal work as well, whether we are doing this transvaginally or transrectally. And manual therapy can include trigger point release, which is really critical for getting full range of motion back to the muscles of the pelvic floor. Depending on a person's own unique needs, we may teach them how to use a pelvic wand so that they can do that manual release at home. And I'll link that wand in the slideshow and talk about it a little later so you can see it as well. Joint mobilizations, myofascial release, which is focusing on releasing tension in the fascia, which is the non-contractile connective tissue that surrounds the muscles. Our fascia is a fascinating, living, breathing organism in the body. So tending to the fascia is a huge part of pelvic floor therapy. Cupping, dry needling, treatment of trapped pinched nerves and ligaments, muscle activation in any part of the body, but in the pelvic bowl especially, this is where that internal exam can be so helpful, because we have a lot of sensation in our pelvic floors, but we do not have a lot of proprioception. So that's knowing where your joints are at in space, knowing if a muscle is contracting, relaxing. We have less proprioceptive fibers in those muscles. So having the feedback of a therapist to be doing an internal exam and telling you what they are feeling your muscles doing as they ask you to contract or relax or breathe can be really, really helpful. And having that feedback as we are working to re-coordinate these patterns to be in an appropriate pattern. And then just like you might see in an occupational therapy or physical therapy session that's not focused on pelvic floor, we do work on mobility, strength, balance, and weight training. Okay, so let's practice one of those treatment modalities. Let's practice some breath work. So if you are in a position where you can use your hands, I invite you to bring one hand to your chest and one hand to your abdomen, to your low belly. And just start to take a breath that feels natural for you in your body. And as you are breathing, notice, are you feeling more movement in this top hand? Are you feeling more movement in your bottom hand at the belly? Good. And then bringing your hands to the lower ribs here. Place your hands with your thumb behind you, fingertips around the low ribs. And again, taking your breath there, notice, are you feeling any movement at the low ribs as you breathe? And now let's assess a deeper breathing pattern in our bodies. So bring your hands back to that chest and low belly space. Now take a deeper breath in your body as if you're taking the deepest breath of the day. Noticing here more chest, more belly, balanced as you take a few breaths with that deeper pattern. And then again, bringing your hands back to that low rib area, thumb behind you so you can feel all around the ribs. And with a deeper breath, what movement are you noticing at the rib cage? And then if you're noticing more in your chest or minimal rib cage movement, go ahead and put in the chat what you're noticing in your breathing patterns as you assessed both a normal breath and a deeper breath. Yeah, I'm seeing some people with more in their upper chest and kind of feeling that at lower rib cage. Some people more in that deep belly breath. Okay, so let's show that anatomy and talk about what we're looking for with a diaphragmatic breath to pelvic floor, and then we'll practice again. So again, like we said, respiratory diaphragm is on top. We actually have 3 diaphragms in our body, our throat and our glottis. So the way that you make sound will activate different areas of your pelvic floor, which is just fascinating. Our respiratory diaphragm and then our pelvic floor muscles. And these are the horizontal bands of musculature in the body that help control intra-abdominal pressure and help manage the system. So as we inhale and our lungs sit on top of this respiratory diaphragm, as we inhale, the lungs will fill with air and this respiratory diaphragm will move down. Theoretically, in a healthy system, the pelvic floor should be gently moving down as well, getting a stretch. And as we exhale, respiratory diaphragm goes back to its resting position and pelvic floor recoils back to its resting tone. So as we're breathing in this way, we are getting we're getting better range of motion to those pelvic floor muscles. We are stimulating that rest and digest, feed and breathe. We're also massaging all the internal organs that are a part of this system. So what we're looking for with a diaphragmatic breath to pelvic floor is a kind of equal 3 parts. So a third part at the chest, which none of us really have to worry about. We all get enough in our chest. A third part around our rib cage, and that's where we're actually talking 360-degree rib expansion. So we want it to be moving in this bucket handle type motion as we inhale all the way to the back where your ribs connect to your spine in that bucket handle motion. And then a third part in this low belly pelvic bowl area. Okay, so now let's take a diaphragmatic breath here with a focus on pelvic floor. If it's helpful for you, putting hands on body is great. I really love to have my hands around that low rib cage to practice 360-degree expansion on all 4 sides. So let's have you take a deeper breath, imagining that your breath is traveling all the way down to the pelvic bowl on the inhalation. This kind of downward and out breath. You can visualize an umbrella here, opening down towards pelvic bowl and out with the rib cage. And then just a passive exhale as you let the breath go, really letting it just passively return to your resting position in your body. And as you are breathing in this way and taking these deeper breaths, curiously, do you notice any movement at your pelvic floor? And no is a perfectly fine answer. We've really never been asked to feel our pelvic floor move with our breath. We're rarely asked to relax our pelvic floor. Okay, Nicole is saying she feels more movement in the pelvic floor. Amazing with this type of focused diaphragmatic breath. Another way you can check that, internal feedback from a pelvic floor therapist is going to be an absolute yes or no, we're feeling it. But a way that you might check on yourself is just placing your hand on the outside of your sits bones. So where you're sitting down, kind of reaching down, going to the sits bones, and then moving your hand inside the sits bones so you're on the pelvic floor musculature. And feeling, do I notice that as I'm inhaling, that musculature is pressing into my fingers, and as I'm exhaling, coming back to resting tone? So we all know the benefits of mindful breathing, deep breathing, but now you know that it's also beneficial for your pelvic floor muscular tone, range of motion, blood flow, functioning. Okay, so let's talk about what a typical plan of care would look like for someone coming in to see us. We would start with our evaluation where we're looking over their intake form, getting their subjective information. And then we are a trauma-informed practice because we offer the ability for, internal or external assessments. So if folks are not comfortable with or totally on board with an internal exam, then we are going to assess their body in other ways externally. And we don't push anything. We always say there are no have-tos here. This is, your plan of care, your therapy session. So we want to make sure that the client is comfortable with the internal work. And I have had clients before who declined internal work for their full plan of care. So we got creative and worked externally. I will say the internal work does give us the most accurate information to really see what pelvic floor is doing with activity, standing, breath, etc. Our treatment phases at Uplift Pelvic Health and Wellness, we work in 3 phases. So phase 1, this restore phase, this is really where, we are hitting the reset button on the body, making sure muscles moving through their full range of motion, joints are all in alignment, breathing patterns are appropriate, fascia is sliding and gliding, really getting the body in that optimal position. And then the retrain phase is where we're doing more functional core work, making sure that our core and pelvic floor are turning on together and turning off together. And then the reclaim phase is where we're really loading the tissues. So maybe it's weight training, or if someone is coming in for pain with intercourse, maybe that phase is where they're reattempting penetrative intercourse with their partner. I will say including partners in the phases, especially the retrain and the reclaim phase, is really critical for someone experiencing pain with intercourse. And then the length of care depends on the person. So this is another question we had is like, can I go once? Do I just go once to a pelvic floor therapist? And just like the clients coming to see you for mental health therapy need more than one visit, most people need more than that one visit with us as well. Typically on average, but again, it's going to be really individual. On average, I would say at least 4 sessions for each phase. So 4 in the restore, 4 retrain, and 4 reclaim, so about 12 weeks. But very much depends on the person and the individual in front of you. And then we do offer 1-hour sessions directly with the therapist, and care is individualized, so it's going to look different for each person that I see. Some of the education and referrals that I will give to someone coming in that's having pain with intercourse, I always ask about if they have a mental health practitioner, if they're in therapy for mental health, in their evaluation and in their intake form. And most people do that are coming in with these concerns, whether it's individual therapy or couples therapy. And I'll ask a few questions there. How is it going? What are you working on? Do you resonate with your provider, et cetera, et cetera? If they don't have a therapist or a clinician, or they're not really resonating with theirs, I would provide referrals there. I also love to refer out for some breath work, especially in bodies where I'm seeing that they're going to need an hour of just breathing to find some release and some repatterning in their body, and leading them through a full hour of breath work we can't quite do in our sessions. So referring out release breath work with Melanie Rasmussen. She's here in the Salt Lake area, and her class is amazing for pelvic floor release, for that full body release. It's kind of using that Wim Hof style breath work that raises the blood pH. We may talk about nutrition, certain foods that are bladder irritants, that are related to the GI, bowel movements. Talking about, especially as OTs love to do, talking about behavior, routines, and habits. We'll use motivational interviewing here to really problem solve with a client, why they may not be consistent on their home exercise program, when would be a good time to implement that, what are the barriers. And then especially for my folks that are coming in with pain with intercourse, talking about the erogenous zones and the types of female orgasms can be helpful information for them to have. And we may, depending on their openness to it, we may prescribe part of their homework as exploration in one of these areas with or without a partner. Some of the types of female orgasms. This is our uterus here with the vaginal canal. So we have our clitoral orgasm, which is here at the vulva, the entrance to the vaginal canal. We also have our G-spot, which is located on the anterior side of the vaginal canal. So that's closest to like your belly button if your hand was palpating in your vaginal canal. And it's not quite halfway up, usually somewhere before halfway up is that G-spot. The A-spot, or the anterior fornix, is also on that same anterior side, closest to belly button, but it's further up, approaching kind of where the cervix is. Then we also have cervical orgasms, which here is our cervix, the kind of area between our uterus and our vaginal canal. We also can have energetic, sometimes called tantric orgasms, nipple, breath, mental, anal orgasms. So here at the anal sphincter, skin, sensitive parts of the skin, like the back of the knees, back of the feet, and even a coregasm. So those core muscles that are part of our pelvic floor, they operate inextricably with the pelvic floor muscles. So I think it's helpful to kind of talk through erogenous zones, orgasm types, because only 4 of those types are actually in the vaginal canal, and then 6 are outside of it. So it gives this permission, this education, this opportunity to explore the body in different ways, and a little less pressure to, always be on that spot that's causing the dysfunction or the pain that they're coming in with. And then we might educate on emotional foreplay and physical foreplay, provide recommendations there if the client is open to it, interested in it. Okay, so the products that I use a lot with clients experiencing pain with intercourse. The first picture you see there, the rings are made from the pelvic people. They're called the O-nut depth limiting rings. So these go on the base of the penis, and they're stackable. They come with up to 4 rings. So you could use 2, 3, all 4. And really they're going to prevent the penis from as much depth in the vaginal canal. So this is really helpful for those that experience pain with that deep penetration, or their pain location is closer to the cervix. And I love starting off with these right away, because as we are working to rewire that pain neuromatrix, I don't want them to keep having painful sex, because we need to work with their nervous system and that pain neuromatrix. So if they can use these and it makes sex less painful, that's wonderful. They may just be like, this is my thing, I use this forever, or they may use them temporarily, and then as we work with their body and their brain, find that they don't need those by the end of the plan of care. The other wand there that you see is our Intimate Rose pelvic wand. I think everybody needs a wand, whether you have dysfunction or not. The wand is a great tool for getting that manual trigger point release to your pelvic floor muscles to really make sure they can relax and kind of lengthen with breath, which is actually going to make your contraction more effective. I think people have a misunderstanding of pelvic floor. They think we just need strength. I've got to come in and strengthen my pelvic floor, but the vast majority of people that I've seen and worked with need to be able to find that length first, and that's going to make for a stronger contraction. Okay, back to you, Dr. Taylor.
Cool. Awesome. Thank you for sharing, Heather. So now we can get into what this looks like in mental health treatment. So we kind of have a better understanding of barriers, physical, psychological. So when clients come in saying they have sexual concerns, and we kind of get a better sense of, well, what are your goals here? You might hear, I just want a better sex life, or I want to have good sex. And I'm always curious about, what exactly does that mean? What does good sex mean? Is it frequency? Is it duration? Is it variation? Is there a specific outcome that you're looking for? And so one of the best questions we can actually ask our clients is, what is it you're actually wanting when you want sex? And then conversely, for those who are coming in and don't want sex or feel like they have a lower desire for sex, what is it you want when you don't want sex? So again, as the good clinicians we are, we're already kind of doing that in lots of other ways, just sort of exploring that deeper motivation behind the why. So I want to ask you, feel free to just throw this in the chat. I don't have a poll for this, but what do you think our clients are actually wanting when they want sex? A lot of connections being thrown in the chat, emotional closeness, good relationships, pleasure, release, connection, satisfaction, and pleasure, reassurance, action and enjoyment, stress relief. Yeah. Completion of stress cycle. Yes. All great. I think those have all come up in one way or another when I asked this question. So I really like Emily Nagoski, her book that came out this year. So if you're familiar with her famous book, Come As You Are, she wrote one that's a bit more specific to couples. The first book is a bit more focused on kind of solo pleasure and understanding solo sexuality. And so the Come Together book is looking at what that's like in a partnership. And she kind of has asked, she's a sex educator, she's asked this question tons of times, and she's kind of just funneled it down to four main categories, which I think everything in the chat kind of files under these categories. So people coming in for connection, validation, like you said, reassurance, exploration, and pleasure. And so more specifically, people are kind of looking for that sense of emotional intimacy, feeling connected with their partner, and that goes beyond physical pleasure. But again, that kind of need to feel close and bonded with someone. Validation is a big one. So just kind of thinking about sexual activity as a way to affirm one's desirability and worth. So clients coming on kind of maybe low sense of self-worth or self-esteem issues, kind of way to build confidence. Exploration is a big one. So kind of just thinking about being able to try new things or discovering personal preferences, expanding your own understanding of your sexuality. Escaping is a good one that kind of gets lumped under that. And then transcendence for those who are looking at that from more of a spiritual lens. And then the pleasure piece. So, not just physical sensations, but again, that joy and satisfaction that comes from a shared experience. And so, again, when we start to kind of replace sex with pleasure, then we kind of get a better understanding of that. And I hope you see as a clinician, whether you work with clients' sexuality specifically or not, these are all things you're qualified to address. And so, again, just kind of putting that back out there. It's well within our wheelhouse. And so, but I have a couple of fun exercises and ways that we can kind of incorporate or enhance our clients' pleasure. So, this is my favorite part of the presentation. We're going to kind of, once we get a better understanding of what it is that's important to our clients, then we can explore a couple of practices. So again, the pleasure model is all about centering pleasure. There are no rules for this. The only rule that is involved is consent. And I'm going to share some exercises with you. I think you'll find a lot of them are pretty common sense. You could probably come up with some yourself. Very straightforward. You might even be surprised that you're already kind of doing some of these with your own clients in treatment. And a lot of these are going to be more for couples work, not necessarily couples therapy, but to do with a partner. And some of them can be translated into more of that solo practice. So the very first, yeah. Oh, sorry. Here, that was just a summary of what we've already covered today. So here are the main exercises I'm going to be going over. I've got them kind of separated into different categories. So I would say definitely starting off with the first four, and that's going to get a better sense of what's important to the client. It's going to foster communication. It's going to establish boundaries. So I definitely recommend kind of starting with that. And then when we get into intimacy rituals or like dates or specific times set aside for couples to connect, then I have several different ideas of things that you can have those couples use in those date nights or in those hour-long sessions that they're sharing together. And you can use the last four bullet points separately too. In fact, I like to kind of start off with a 3-minute game before even getting into the intimacy ritual or the dates. But I'll go over each one of these specifically. So the first one is just pleasure inventory. What brings you pleasure? Getting a very good list of things that feel pleasurable to our clients. This is going to be not a one size fits all. And I like to get at least about 20 examples of things that feel pleasurable to our clients. Again, not sexual necessarily. In fact, I kind of encourage starting off with non-sexual forms of pleasure. Feel free if you want to share in the chat things that bring you pleasure. I had a couple lists of one of the things, the reason why I added the palm tree picture is just noticing the way light hits the palm tree leaves. That brings me a lot of pleasure. Putting my hands in the dirt, moving my body, going on hikes. I think there are, again, they don't have to be grand or even sexual. So just something as simple as noticing how it feels when you drink a cup of tea or feel the breeze on your face. And so once I have them list the items that bring them pleasure, if they're doing it with a couple, I think it's kind of fun to have them offer observations on what makes it to their partner's list. If it's just them, kind of maybe taking a look at this list and seeing if there are any patterns that come up or anything that feels surprising to the client. And then the most important thing is to encourage daily engagement with these items. There is homework involved in this, where again, we're centering pleasure with the pleasure model. The next one's gratitude journaling. Oh, there's stuff in the chat. Sorry, take a look at. Yeah, these are great. Examples in the chat here. Gratitude journaling is the next one. I didn't add a slide for this. I think I have mixed feelings on this. If you've ever tried to get a client to do gratitude journaling, sometimes there's a lot of resistance. I feel like I have to have a really good explanation and get a strong buy-in before that actually happens. But for this particular type of gratitude journaling, encouraging clients to focus on moments of pleasure or joy. Again, no matter how small. And that's a great way to kind of shift focus from trauma to positive experiences. Gratitude journaling in general is such a powerful tool to kind of reshape our perspectives. And you can just make it specific to pleasure. The next one is pleasure mapping. So this kind of invites clients to identify areas on the body that bring them pleasure. Again, doesn't have to necessarily be sexual. So kind of thinking of it as creating a treasure map to joy. For copyright issues, I kind of include that gif of that scene in Friends, but if anyone's familiar with that, where Monica draws uh, the X's on a body of things, of areas that would bring her joy and pleasure. It's a great scene, but getting like specific with it, and it doesn't have to be physical pleasure. It can be sexual, it can be emotional, intellectual, but really kind of encouraging our clients to expand that pleasure map over time. The next one is having couples create a list of they're unsure about or the activities that they are certain they want to avoid. So again, leading to an honest conversation about desires and boundaries. And so these are kind of the first four that kind of really get to what is important to the client, getting them connected with their bodies, getting them used to communicating that out loud, and figuring out where their own limitations are with that. So then I want to get into intimacy rituals. In the ISTE training that I did, Tammy Nelson refers to these as sex dates. I have since adapted that to pleasure dates. But this is guiding our couples to create a sacred space for intimacy, encouraging exploration of each other's bodies, desires, and no pressure. And so, specifically, I will say take sex off the table starting off. And so, carving out at least an hour each week, I think you'll find there's some resistance to that. And then over time, they actually want longer periods of time for these dates. And you can engage in a number of practices here. The goal really is just to have a set time each week. And I think when you have a set time each week, you find that couples start to look forward to that time. They might experience some form of pleasure leading up to that and kind of think, wow, that felt really good. I really want to have this experience with my partner. So they're kind of like thinking ahead, and it gets them kind of building that anticipation, which, if you've ever like planned a big vacation or a trip, sometimes it's just like the planning and the leading up to it that's almost as satisfying as a trip itself. And so, same thing that kind of goes along into these pleasure dates. So, building it up. And again, starting off doesn't even need to be sexual. So, the first one is just a shared experience. And that doesn't even need to be in the bedroom. So, that's encouraging any kind of pleasurable activity the couple can do together. Again, we're kind of looking at enhancing overall joy and connection. And what we're slowly starting to do here is build positive associations with the partner, with the relationship, with being in the body, even. And so, starting off, again, it could be going to a movie together, going for a walk, skipping stones, whatever brings you joy. Um, the next exercise that I really like to do, and again, sometimes I'll just do this completely separate from the pleasure dates, is the 3-minute game. So that is having couples set a timer for 3 minutes and then just asking for whatever it is they want in those 3 minutes. And again, it doesn't even need to be sexual. It could be for 3 minutes, I want you to listen to me talk about my day, or I just want you to hold my hand, massage my feet, whatever it is. And of course, the partner can say no to that. This is all about consensual conversation here. Timer goes off, they switch roles, and then the other partner does that. And you can do it as many forms as you want. Again, sex is off the table here. I think a lot of times couples, I hear a lot from one partner that they want to be physical or intimate, but they're worried that's going to send a signal to their partner that sex is then going to follow, which puts pressure, which makes them retract. And so this is really a good exercise of you can be intimate and not expect it to go somewhere. Kind of going back to the pizza analogy, you can order a pizza and decide you actually don't want any of it. So really kind of taking the pressure off of that. And then it gets them really connected to what they want. I think half the battle is a lot of times we don't know what we want. We don't know what is pleasurable. And so kind of getting connected to, in this moment, I actually don't want to be touched right now. I just want you to stare into my eyes or whatever might feel good. And so getting them really connected with what's important to them and being able to then communicate that. Communication is key. And I think you'll start to see couples who do this over and over again. It's really kind of adding to that responsive desire. You don't have to have the spontaneous to feel that sense of pleasure. Then there's just playfulness. There is a ton of great research out there about how powerful playfulness in general, not sexual even, is. And then connecting us to that part of ourselves that kind of see things through fresh eyes, having a bit, feeling like your experiences are novel. So same thing happens in a pleasure context. Just really kind of figuring out what's fun for a client. Laughter can be incredibly erotic. And so just again, no pressure. We are taking the pressure off of performance or having to go in a step-by-step process and really kind of just having a bit more of a less linear, more of a flow to what comes up without, again, expectation. And then the last one, there are a lot a lot of pieces here in the last one. I think I'd like to do a couple if we have time. Yeah, we could do a couple of these together. So there's mindfulness and body awareness. So again, just thinking about pleasure living in the body. Um, I like this example that I think that was in Come Together, where basically pleasure is like this shy animal. It's there, it's in our body, but it's not going to come out unless we kind of give it permission to. Whereas pain, trauma, fight or flight, right? Like those are the things evolutionary we've marked to be most important. They're going to take precedence. And so, really kind of taking a step back, getting in our bodies and giving pleasure a chance to come out. I kind of feel like these exercises get to that. Pleasure is all about being in the present moment. It's about being able to get out of the thinking mind, which for some clients, that is very difficult. And so, I really like to try these exercises out with clients in session. Well, the first two in session. So, first one is just getting out of your head. So, the quickest way to shut off our thoughts and our thinking mind without having to do years of mindfulness exercises is, and I'll invite you to try this if you want. You can take a neutral gaze, close your eyes, but just imagine going to the back of your head. Shifting awareness, what's back there? So, if you're noticing kind of that stream of conscious thinking slowing down, that's the purpose. It's a super simple, super straightforward. So, again, quieting the thinking mind. The next one is a body scan for pleasure meditation. And I think there's this overlap between sensuality and pleasure. And by sensuality, I mean focusing on our senses in a pleasurable way. Um, I think every time we do a body scan, or at least for me in the trauma therapy that I've done, it's like I'm doing a body scan trying to figure out where are the areas of tension that you're noticing, what areas don't feel good in your body. And we're just putting awareness on the stuff that isn't feeling good. So for a body scan, to focus on pleasure instead. So really scanning the areas of the body that feel good or relaxed or alive. You can encourage exploration of non-sexual sensuality. If you've ever had clients do the 5, 4, 3, 2, 1 grounding exercise, I really like flipping that around and doing just things that bring pleasure to your senses. And so usually like noticing one thing that tastes good, I'll start with the taste for the 5. So noticing 5 things that taste good, literally inviting them to bring in foods that they like, drinks that they like, 4 things that they like to smell. So really kind of setting the scene for them, things that again smell pleasurable. 3 textures that feel good, having them describe the textures. 2 sounds that they like to listen to, and that could be music or just maybe if they have like a sound bowl or something. And then noticing something that looks pleasurable and play around with the numbers, but basically, what is pleasurable to your senses for that? And then there's the body awareness of pleasure. And so, what is it like to live in your body? And again, if we're talking about clients who have had a lot of trauma, it might be difficult or feel threatening to get into the body. And I think there are a lot of really good practices, like embodiment practices out there. I put 2 books that I've loved using that have some very straightforward practices you can have clients try out. And so I'm gonna let's just do. I think we have time for just one of these, but this is probably my favorite exercise, which is in the Sensual Self book that's on the slide. But I want to just take a second, again, if you feel comfortable, closing your eyes, neutral gaze, getting comfortable in your chair, and just having your palms upturned. So palms facing the ceiling, nothing touching them. This can work on any part of the body, like top of the head or elbow or roof of your mouth. But let's just focus on the palms for a second. And I want to ask the question while your eyes are closed, how do you know your right hand is there? You can't see it. You're not directly touching it. How do you know your right hand exists? You might start to notice a tingling sensation. There might be a warmth there. That sense of aliveness. See if you can isolate it from the rest of your body. And then switch it over. How do you know your left hand is there? If you can't see it, you can't feel it. And then, of course, you can play around with other areas of the body, ideally starting peripherally, working your way to the genitals, but really getting a sense of what it's like to connect or put your conscious awareness in different parts of the body, because I think so often we live in our frontal lobes. And then going back to, and by the way, I think clients who have had some kind of somatic therapy or are used to kind of being in their bodies tend to report experiencing a lot more with this. That might not be the best one to start with, clients who haven't had that. And then with the pleasure dates, we're not going to do this one together, but I like to encourage couples to try this out where, they're setting aside an hour each week to connect without the expectation of having sex. And really, we're trying to create a space that allows pleasure to come up without any expectation. And so you can start by just focusing that same, like you did on your right hand, focusing that on your partner. So you can caress, kiss, stimulate your partner, allow the pleasure to grow, and then go ahead and just retract. Create some physical space between you, allow that pleasure to dissipate. And again, starting on the periphery of the body. So non-sexual parts, just practicing what it's like to build that pleasure, create some space, let it dissipate. And then just doing it over an extended period of time, like a luxurious, extravagant, extended period of time, half hour, hour, and maybe that's the entire pleasure date. And maybe the next week they switch. But what you're trying to do here is really playing around with that rise and fall, that expand and contractive pleasure. No expectations. Sex is off the table. And then maybe by week 3 or 4, depending on where the couple is coming from, then you can kind of allow that to include genitals. But sensuality is all about kind of slowing down pleasure and allowing for that buildup. So when we introduce these exercises to our clients, we need to be very clear about why we're having them do this. So explaining the purpose, making sure we're setting appropriate boundaries, and then please make sure to follow up with them in subsequent sessions. I think that's a frustrating experience for clients to be told to try something and then we never really invite them to share how that was. And then, yeah, here we're just trying to encourage clients to take their time, explore at their own pace, and then focusing on what feels good rather than what they think should feel good. Okay, so let's just summarize here. We've explored why addressing sexuality is crucial for comprehensive mental health care. Really is important to normalize sexuality in therapy just as we would other aspects of mental health. And just empowering you, you already have the tools and knowledge to start these conversations. And it's a bit more accessible if you frame pleasure as the therapeutic tool. You don't need the expensive trainings or a complete overhaul of your practice. Really small intentional steps can make a significant difference in your clients' lives. And then one motivational message: by embracing sexuality in your practice, you're opening doors to holistic healing for your clients. So I'd like to just challenge you to maybe try one of these exercises in your practice, maybe try it personally, see what you notice. And then I am including a ton of resources if you're interested for further exploration, books, online resources, webinars, things at the end of these slides. But just to conclude, we're really kind of looking at sexuality as a really important part of holistic care. I would like to acknowledge an important aspect we haven't touched on today, and that is the concept of energy flow and sexuality. We focus pretty much on the mental and physical aspects of pleasure and sexuality, but I just really want to say there are a ton of cultures and traditions throughout our history that have recognized a much deeper energetic and even spiritual aspect of sexuality. If you're curious to explore that, I have a ton of resources. I'm very interested in this topic. I'd even be happy to offer a separate, maybe non-CE approved presentation. So just reach out, let me know. I'm always eager to kind of discuss diverse approaches to sexuality. So I'm hoping that you feel much more confident that you can address sexuality and pleasure in therapy. And I just want to thank everybody for joining. And I know we're at the end of time, but just a reminder, you will get a copy of these slides, you will get a copy of the recording, and then we do offer CEs for occupational therapists as well, so just for mental health professionals. And if you have some time to stick around, Heather and I will hang out for a bit if you have any questions. It's like we got a couple questions in the chat, and it's looking directed at you, Heather.
Yeah, I see one from Cami regarding pain during intercourse. Do you refer for local vaginal estrogen for women in menopause? This is a great question. Pelvic floor therapists cannot prescribe medication, so this would be something coming from the gynecologist, physician. But yes, I have seen major success with topical estrogen. So in that condition of vulvodynia, which is that burning, painful irritation at the vulvar tissues. We see that it can be caused from a number of reasons, inflammation, trauma, mental, nervous system, and also there is a hormone-mediated vulvodynia. So we do know that the change in our hormones during menopause can have those lasting changes to the tissues. And research has shown, and what I've personally seen in the clinic, is that topical estrogen right at the vulva, at the vaginal entrance, is really beneficial for, bringing pinkness back to the tissues, reducing pain, reducing that redness and irritation. And then I see another.
Add real quick before you jump on to Cami, definitely refer you back to Dr. Witt Sandal Scholar's presentation that she gave several months ago on our website. She kind of covers some of that there too. Sorry, go ahead.
Yeah, great. I'm seeing a question here about the Kiwi product that's new from the Pelvic people. They have some really fun marketing for this product if you are curious to check them out on their website or on Instagram. But yeah, this product, it's really new, so I haven't personally used it yet with clients, but the way that they are using it with promoting that relaxation and that calming touch to the body prior to going straight to the genitals or straight to the vulva. And then it does have nice curvature and like vibration features on it so that when the body is relaxed around that area, you might then begin to use it on those vulvar tissues. So we do a similar method using kind of that vaginal wand. We teach people how to use that externally as well as internally. And also I'll have people try with their fingers or with other instruments that they may already have at home so they don't have to buy a full new product. But I am excited to give that one a try because there's been a lot of excitement about that new Kiwi product. Yeah, hemorrhoids don't necessarily always happen because of the pelvic floor congestion syndrome. Hemorrhoids are, primarily caused by this core intra-abdominal pressure management. So the core system is this intra-abdominal system. And if we're not managing the pressure correctly, you're going to experience bulging in one area of the system. People, sometimes can get hemorrhoids, down on the vaginal canal, or if you had a bulging forward, that would be maybe more of like a diastasis than an abdominal hemorrhoid, but the abdominal hemorrhoids have happened as well. So it's really poor intra-abdominal pressure management, and that is 1000% what we teach in pelvic floor therapy, how to manage that pressure in your core system with, the breath, the core, and the pelvic floor working in sync together so that they're really turning on to support when you need that support, so that you're not going to have a pressure bearing down and out, and then they're turning off to relax when we need them to be turning off. And if someone has an active hemorrhoid and is in, active pain, then we'll modify, and we may not do a transrectal exam on the day where they're having this like active hemorrhoid and pain. Just like, providing that individualized care, and, with that background in pain neuroscience, to know, are we treating the body in a way that they are not going to perceive as a threat, that is going to help to rewire that pain neuromatrix. Yeah, there's so much we can work on during pregnancy. So I'm like a huge advocate of coming in during pregnancy, not waiting until after to then do the postpartum recovery, because if you know the pressure management skills while you are pregnant, that's going to help prevent hemorrhoids, prevent the risk of tearing during birth from, I think the research shows, from a
Oh, wow.
grade 4 to a grade 2. Yeah, some really major things that we can help the body with during pregnancy.
Bye. Thanks, everyone.
Thank you.